So glad that all of you are here for the first seminar sponsored by the Blue Cross Blue Shield of Alabama Chair in Health Economics Endowment. I am Pia Sen. I am currently the holder of the Blue Cross Blue Shield Endowed Chair in Health Economics, and I am so excited that today we get to speak or get to have a discussion about one of the most pressing issues in health economics and health policy of our times. Tomorrow, the Supreme Court of the United States is going to hear arguments that may decide the future of the Affordable Care Act, also known as Obamacare. So today we are going to have what is partly a seminar, but also more of a conversation really about the Affordable Care Act and predicting a little bit about what's going to happen with my senior colleague, Dr. Michael Morrissey. So Mike Morrissey is a health economist, professor emeritus of health economics at UAB, professor emeritus of health policy and management at Texas A&M. And Mike's research interests have focused on employer-sponsored health insurance, effects of legislation and regulation in healthcare, outcomes research, health economics. And I will say, when I posted about this seminar on Twitter, another health economist from another university commented saying, Mike Morrissey is the man who knows everything about the ACA. So there's that. Dr. Morrissey was a founding officer of the International Health Economics Association, and he recently completed his term as an officer of the American Society of Health Economists. He was the first recipient of the John Thompson Young Investigator Award in Health Services Research, given by the Association of University Programs in Health Administration. While at UAB, Dr. Morrissey directed the Lister Hill Center for Health Policy and was the co-director of the Centers for Outcomes and Effectiveness Research and Education. At Texas A&M, he was the head of the Department of Health Policy and Management. He was also adjunct professor at the Bush School of Government and Public Service. And I should say today, this seminar is partly courtesy of Lister Hill Center, who've been running the whole web program, I couldn't have done this without them. So I want to give a shout out to Suzanne Judd and to Sean McMahon for really making this possible. And so I'm going to turn this over to my colleague, my friend, my mentor in many ways, Dr. Mike Morrissey.
Good afternoon. I'm delighted to be here, and I'm proud to be the first of the Blue Cross Blue Shield chair seminars. What I want to do is really talk about four issues. First, a little bit of background talking about what the ACA has accomplished and some of the issues that are out there. Second, I want to talk about sort of the future ex ante. That is to say, what would likely have played out in the absence of the Supreme Court case and the change in administrations. Then I want to spend a fair amount of time talking about the Supreme Court case that is heard tomorrow, California versus Texas. And then finally talk about the Biden administration and the sorts of things that they have in mind for the ACA. And as we go along, he has promised to interrupt with all sorts of questions. So first off, the accomplishments and issues. So everything you want to know about the ACA in one slide. First, it mandates health insurance coverage for both individuals and for larger businesses. Larger being, a term of art, 50 or more full-time employees. It also eliminates pre-existing conditions in underwriting, such that the premiums are set based on one's age and where one lives and whether or not one's a smoker. The ACA also puts in place penalties and subsidies. Those penalties originally were essentially one had a subsidy that would allow you to buy health insurance if your income was between 100 and 400% of the federal poverty line, and the penalty imposed a penalty on you if you chose not to purchase health insurance. Now, what the Congress did in 2017 was to set that penalty to $0 and 0% of income.
Mike, if I can interrupt here for a moment. So the Congress sent the individual penalties to essentially nothing. But even before that, would you say that the penalties that came with the individual mandates sort of had enough bite to them to really accomplish what they were meant to do, which is to strongly incentivize young healthies to get into the pool so premiums stayed low?
No. Essentially, the penalties were too thin to have a big impact at all. Essentially, the penalty was as much as 2.5% of your income. But that's wasn't big enough to have a big impact at all. And indeed, the Congress put that penalty to 0. It's important to keep the penalty in mind because that's part and parcel of what's going on with the Supreme Court tomorrow. The other important thing that happened in all of this is the Trump administration encouraged short-term policies. And so by virtue of a little bit of a footnote here, in the olden days, one would buy a short-term policy when you graduated from college and your job didn't start till January. And so you bought coverage to cover those few months. Or you were moving from one job to another, or maybe you had a health problem and no coverage, and so you would buy the short-term policy. But typically it was intended for a narrow window. What the Obama administration did was to define short-term policies as being able to exist for no more than 90 days. Ordinarily, state law would say what that was. What the Trump administration did was to expand the definition of short-term policies so they could be as long as 365 days. So what that means is one could buy these sorts of short-term policies. You can't get them on the exchange. They are in fact don't provide the essential benefits that are required, and they're medically underwritten. But the idea was that this was an opportunity for some people to get coverage outside the exchanges at arguably lower prices. So that's the mandate side of the act. The other thing the law did was to provide Medicaid expansion. It required that all states were to expand their Medicaid program. And if they didn't, they would lose all of their federal matching funds. They would lose their funds for kids, for pregnant women, for the disabled, for those in nursing homes. And the Supreme Court back in 2012 said that this was a step too far. And what they did was to allow states to participate or not, taking advantage of the subsidies that Congress provided. But if they chose not to, they wouldn't lose all of those matching funds. And at the moment, some 38 states in the District of Columbia have chosen to expand their program. Alabama and Texas, and indeed many of the states to the Southeast and the Midwest have chosen not to.
So Mike, if I can ask you this, so this Supreme Court decision, this ended up doing something like creating a coverage gap, right? Because the subsidies in place were not designed to cover the people that the original framers of the law thought would be covered under Medicaid expansion.
That's exactly right. I mean, that what the Congress intended was that if your income was below 138% of the poverty line, you would be enrolled in this expanded Medicaid program. If your income was 100% of the federal poverty line or above, you were eligible for some subsidies. So there's a little bit of 100 to 138% overlap there. But when states didn't expand Medicaid, that meant that folks below 100% of the federal poverty line weren't eligible for Medicaid through the expansion and weren't eligible for subsidies through the exchanges. So this is, a fairly well-known slide from the Kaiser Family Foundation. Prior to the ACA, and while the law was enacted in 2010, not much really happens till 2014. So we're really talking about 7 years worth of effort for the most part. But prior to the exchanges coming online, there were something like 44 to 45 million folks under age 65 who lacked health insurance. With the advent of the ACA, the number of uninsured dropped to 26, 27 million. Originally, the CBO estimated that it would be something like 21 million people that would be without insurance. These higher numbers reflect the fact that all those states didn't implement the law. And so, as you see, as of 2018, about 10% of the under age 65 population still lacks health insurance. Well, laying out as the ACA rolled out, there was a lot of tumult that went on. First of all, it turns out that insurers knew very little about what sort of claims experience they would expect. I mean, you're talking about a group of people who didn't have health insurance and insurers who knew about people who bought coverage in the individual market, and they knew about the small group market, but those weren't necessarily representative of what they were going to see. And data flows in slowly. So you open your enrollment period in November, it starts in January, people have to see their docs, claims have to be submitted, and you have to file in June with your state with respect to what you're going to do next year. So it turns out the insurers had very little information with respect to claims experience. As it turns out, there was substantial adverse selection. Adverse selection means that you as a purchaser of health insurance know a whole lot more about your likely use of health services than does the insurer, and you're going to use it to your best advantage. So there's asymmetric information there. And what happened was substantially more sort of sick people joined the exchanges.
And this is going back to the fact that the mandate really did not have any teeth. So healthy young people.
Well, that's right. So you disproportionately had sicker people joining. Now we had some funding from the Brookings Institution to do a series of field studies, and I was responsible for Texas. And I remember talking to an insurer in Texas, and I said, "Come on, you knew you were going to get sicker people." And they said, "Well, yeah, we expected, a third higher than the standard enrollees in the individual market." It turned out they were 75% higher in terms of claims experience. So it was a much worse experience than they anticipated. And as you recall, what sort of happened after that was that there was initially an uptick in the number of insurers offering coverage in the second year actually of the exchanges, and then after that a rather rapid decline. I mean, in Texas, there were 16 insurers in the exchange market in 2016 that fell to 10 in 2017, and now it's only 8. Now, even those numbers are somewhat misleading. Those 10 insurers in 2017, only one of them covered the entire state, and 6 of them only covered 11 of the 254 counties in the state. So, the number of insurers declined rather rapidly as insurers came to appreciate what the claims experience was going to look like. The other thing that happened is it turns out that consumers were very price sensitive. You may recall discussions about people not looking at what a deductible meant, just going for the cheapest plan they could find. But some pretty good evidence has come out since indicating some rather substantial price sensitivity here. The other thing that happened is basically by 2017, the insurers that were still in the market pretty much understood what was going on. And they raised premiums rather substantially, particularly in 2017. And what we've seen since that time is that the premiums have been fairly stable. I mean, they up a little bit every year, but they've been fairly stable.
So Mike, you said about the consumers being price sensitive. So there were about 4 types of plans offered, and they all have names of different metals. And it's largely a function of premiums were low, which meant copays and deductibles were high, and premiums were high meant copays and deductibles were low, right?
That's right. There were bronze, silver, gold, and platinum plans. Now, if you purchased a bronze plan, the insurer would pay 60% of the claims experience. You were on the hook through deductibles and co-insurance for the other 40%. If you wanted a more generous plan, you would move to silver or gold or platinum. Now, it turns out there are very few platinum plans out there and not very many gold plans out there either. I mean, silver is the most popular, bronze coming secondly. So we've got this stability of the premiums that sort of play out after 2017, but then the short-term policies come along, and we really don't have good information on them, but potentially a threat to the exchanges and the end of the penalties. And to the extent that the penalties end and I'm young or healthy and I was in the exchanges, the penalties are gone. Maybe now I don't want the exchange. Maybe I want a medically underwritten short-term policy because I'm healthy and so in any event, the tumult sort of continues. But having said that, the enrollment in the exchanges has been fairly constant. In 2014, the first year, you remember all of the chaos with respect to websites that didn't work. They got about 8 million enrollees. That went up to as high as 12.7 million in 2016. And it's slipped a little bit since, but been fairly stable. By 2020, the estimates, and these are from Kaiser Family Foundation, of 11.4 million people with coverage through the exchanges. But this is a little bit misleading. And certainly you wouldn't believe that there would be a whole lot of price sensitivity given these numbers. These are data from CMS. And they do 2 things. They look at the enrollment for those who got a subsidized plan and those who didn't. Now, it turns out, if memory serves, about 85% of those who enrolled in the exchanges got a subsidy. And the upper bar here represents their enrollment over the period through 2019. And as you see, it's pretty stable. On the other hand, the lower trend line are those that didn't get a subsidy. And their enrollment was lower, and then it starts dropping off beginning in 2017 as premiums go up and continue down into 2018 and down a little bit in 2019. So in some sense, what we have are sort of 2 very different populations here that revolve around the exchanges. On the one hand, we've got the subsidized and sick who have largely remained in the exchanges. Little effect of premium increases on them because the way the subsidy is set up is if your income doesn't change, your subsidy continues to, you pay no more out of pocket, even if the premiums go up a lot. And if you're sick and you have pre-existing conditions, you have coverage now, and so you have an incentive to stay with the exchanges. So from that perspective, for that population, little affects the premium increases, little effects of the elimination of the penalties. On the other hand, for the unsubsidized and healthy, they withdrew from the exchanges or in fact never joined.
Mike, to be unsubsidized, you have to be above 400% of the federal poverty level, right?
That's correct. That's correct. And it varies, as you know, with respect to federal poverty lines. It's your household income and how many people are in the household. But on the unsubsidized side, what you should expect and what we saw was substantial withdrawal from the exchanges, very price sensitive consumers on the off exchange market. Now, you can buy coverage that looks just like the exchange coverage, bronze, silver, and so on the exchange or off the exchange. If you buy it off the exchange, you don't get you certainly don't get a subsidy, even if you were eligible. And typically you would buy it through an agent probably. But very great price sensitivity there, and that substantial potential in the short-term markets. So that's the setup. Now, what would we expect to see playing out in the absence of the court case and with few changes in the administration? Well, my sense is the ACA would largely remain just as it is. The exchange enrollment and the Medicaid enrollment would be fairly stable. Congressional Budget Office estimates that Medicaid would represent about 2% of gross domestic product, and the exchange subsidies would represent 0.2%, 0.5%. I can't see behind the window here, over the next decade. So fairly stable going forward.
Mike, is the Congressional Budget Office assuming or projecting that more states will want to expand Medicaid? I know it was probably a ballot initiative even in 2018, I think.
Well, see, the usual rules that CBO applies is that they have to apply existing federal law. So their assumption is pretty much steady state going along here. One might have imagined that states that hadn't expanded would consider expanding now. The issue comes down to, yes, you've got a whole lot more people who are uninsured, as we'll see in a minute, as a result of the pandemic, but you've also got states who are pretty uncertain about what their revenues are going to look like. And so I know there have been, prior to the election, efforts to encourage the 12 states to expand. I'm pretty skeptical as to whether or not many of them would have done so. The complication with the ex-ante estimates, of course, is the pandemic. Families USA estimated that there were some 5.4 million people that have lost health insurance. And what that suggests is there should be an increase in exchange enrollment. There should be an increase in Medicaid enrollment where possible, and possibly an increase in these short-term policies.
So the healthcare exchange enrollment is open as we speak, or is it over now? Is the window
closed? Yes, it opened November 1st, and it's through, if I have it memory correct, December 15th.
Okay, and one thing I heard on NPR today is the Biden administration may make that enrollment continue to stay open down the road in view of the pandemic.
Right, although they clearly, there would be a gap presumably until the administration came to office. Well, it turns out there are some estimates out there with respect to the exchanges and to Medicaid. This is data from CMS, and it turns out there are special enrollment periods. I mean, there's the open enrollment period that we just talked about, but afterwards, if you lose your job, for example, you are eligible through the special enrollment period to sign up for coverage through the ACA. And so what CMS has put together is the number of people who have enrolled through the special enrollment period between typically the middle of December through the end of May. And so what you see for 2020 is a relatively large increase in the number of people who have enrolled through the special process. And the dark portion of the bar here is those people who enrolled because they lost coverage. So you should expect an increase in coverage in the ACA. These are relatively minor numbers, small numbers, but that's probably to be expected given that, if you've lost your job, you don't have income coming in, you'd still have to purchase coverage, maybe with a subsidy. And indeed, if your income's below 100% of the federal poverty line because you've been laid off, you're not eligible for a subsidy. On the other hand, we should expect increased Medicaid enrollment. CBO in September put out their revised budget estimates, and they anticipate an 8 million person increase in enrollment in Medicaid in 2012, a $57 billion increase in spending in 2020 relative to 19, and a $21 billion increase in spending 21 relative to 20. Now, part 71. Of this certainly is due to the new enrollment, but part of it is also due to Congress sort of continuing the window of enrollment. Those folks who have looked at Medicaid know that there's churning in the program. You're eligible for the program for a few months, and then you're not, and maybe you are again. So what the Congress did was to allow people to continue enrollment over the course of the pandemic.
Okay. So at the 71 billion projection for 2021, that's still assuming the pandemic's continuing as it is and all the economic fallout is continuing.
Right. Yeah, on the presumption that that we don't get back to the old world very quickly, and clearly, I don't think anyone thinks we do. And finally, the short-term policy thing. But there are no clear estimates, and it's important to appreciate that while there may be large increases here, those short-term policies have limited coverage. For example, you're almost certainly not going to have maternity coverage. They're medically underwritten, so if you have existing health problems, they're probably not for you. But on the other hand, you've lost your job, you're relatively healthy. It may be an inexpensive way to provide, sort of financial protection until you get another job. So, the future ex ante. Which brings us to the court case, California versus Texas, and the Supreme Court seeing us tomorrow. Now, as you all appreciate, I'm not a lawyer. I'm certainly not a constitutional attorney. I've read some stuff, some of which is very readable and some of which is not at all. And I've had some nice conversations with Jack Nelson, who taught health law in the School of Public Health at UAB. I should point out none of this is necessarily his point of view, but here we go. So to give you a sense of timeline, so 2012 was the big Supreme Court decision, NFIB versus Sebelius. The court ruled 5-4 that the mandate was constitutional, but the only reason it sort of made it that way was because Chief Justice Roberts basically saved the law by arguing that the mandate linked to the penalty was a tax. That the four dissenting judges all argued that it was unconstitutional and that it wasn't sort of supported by sort of the tax treatment, but it was Chief Justice Roberts' sort of link here. And one way to think of what he said was that it works because what the Congress did was to provide consumers with a choice. They could buy health insurance or pay a penalty. And so that worked. 2017, Congress set the penalty to $0 and a 0% of income. 2018, Texas and 17 other states and 2 individuals, and it's important to keep these 2 individuals in mind as we go forward, but Texas and the others brought action that the mandate was unconstitutional due to that lack of savings, since there wasn't the link anymore. Presumably the dissenting opinions that it was unconstitutional would hold. 2019, California and 20 other states appealed. Oh, and I should say the district court in Texas held that the law was unconstitutional and that the mandate was non-severable. That is to say, you couldn't separate it, and indeed the whole law was unconstitutional. 2019, California and 20 states appealed. The Fifth Circuit Court in New Orleans held that indeed the law was unconstitutional, but it remanded the case back to the federal district court to look at this severability issue. The idea being, well, maybe there are elements of the law that are unconstitutional, but can they be carved out and set aside such that much of the law could continue?
So, Mike, if I can ask you this, I haven't read the total details of the lawsuit, but is there something in there that says, and if the mandate is not constitutional, then the law is no longer required to cover pre-existing conditions at this with sort of zero medical underwriting, that pre-existing conditions is no longer.
The answer is that depends. I mean, there is not language in the law that says that if some segment is declared unconstitutional, the rest remains. The courts can interpret this however they want, and that's the issue of severability that we're going to talk about in a moment. The final step here is in 2020, California and the other states appealed directly to the Supreme Court. And that's why, and the court agreed to hear it, and they do tomorrow. So what sort of outcomes can we expect? It turns out there are several, and I've listed 4 of them. The first one is there is no penalty because the Congress set it to 0 now in the law. Therefore, there is no linkage between the mandate and the penalty. Therefore, the mandate is unconstitutional. And from that perspective, the mandate goes away, the essential benefits go away, the subsidies go away, the pre-existing condition exclusions go away. And indeed, the court could say the entire law is declared unconstitutional, which is what the federal district judge did. So that's outcome 1.
So Mike, I have a quick question here. I was at one of the various meetings with Senator Doug Jones before the elections happened, and he said you could set a mandate of 25 cents and this would all still be constitutional. Is
Arguably, yes, although presumably we would go through a whole series of court cases to get back there, but you might not even have to do that. That's outcome 2. So outcome 2 is the court observes that indeed there is no penalty, but they buy into Justice Roberts' insurance choice model. And I mean, what happened with the original law is it turns out that there were groups of people who were exempt from the penalty. So they faced a mandate, but if your income was below the level in which you had to file federal income taxes, you weren't subject to paying the penalty. So to some extent, there were already excluded groups. So what the court could do is to say, we're going to continue to follow Chief Justice Roberts' model. And it's now simply that the excluded category is more than just those folks that didn't file income taxes, it's everybody. And from that perspective, the ACA continues to be constitutional. There are no changes. Or a third option is that the plaintiffs lack standing. Now, what I've learned is that standing actually has 3 components. First, the plaintiff has to be harmed. Think of those 2 people that were part of the original Texas suit. First, there have to be people that are harmed, or entities that have to be harmed. Second, the harm has to be, caused by the law. And thirdly, the harm has to be redressable. And so the argument here is, I'm one of those 2 individuals that are part of the original plaintiffs. And the way I'm harmed is, yes, you set the mandate to 0, but I'm a law-abiding individual, and I realize that the law still says I should buy coverage. And when I go to buy coverage, I find that the coverage is much broader than I wanted because of the essential benefits, and I have to pay a high premium because the pre-existing condition clauses there aren't there. So
Mike, can I ask you to elaborate, because this has come up a few times now. Can I ask you to elaborate a little on essential benefits for those who might not be completely familiar with it?
So what the law did was to specify 10 categories of essential benefits, things like hospital care, physician visits, maternity care. There's 10 of them. And what many of us thought that would happen when the law went into effect was that the Health and Human Services would put together committees that would identify what the law was. They didn't do that. Basically, they told each state to identify a benchmark plan that identified what these coverages were. So it specifies a broad set of coverage. So these two people say that they have been harmed by all of this. Now, from an economist perspective, you can say, yeah, that makes sense. I can understand that. But it appears that from a constitutional law perspective, that's kind of a stretch to go that far. And so there's an argument that says that the courts indeed have been way too generous in sort of allowing standing, and that maybe what the court is going to do is to use this case to sort of push back and to say, these folks don't have standing, they haven't been harmed, or at least whatever harm they had maybe isn't caused directly by the law. So in any event, they lack standing. The case is essentially thrown out, and the ACA continues to be constitutional. Fourth outcome, severability. So here's the earlier discussion that you raised, Pia, about sort of, well, what about various elements? Well, under under severability, an unconstitutional element of the law can be stricken, but the rest of it can survive, depending on the court's interpretation of all this. Now, it turns out that my sense is that general judicial preferences are to save the law. I mean, Justice Robertson in the original case said that every reasonable construction essentially must be considered to try to save a statute from unconstitutionality. If you may recall, with Justice Barrett's hearing, she made similar kinds of comments with respect to whether or not you declare whole laws unconstitutional or you try to separate the parts that are a problem. And maybe a third example is when you look at the case back in 2012, when they dealt with Medicaid, they didn't just scrap the whole law. They said the federal matching dollars associated with Medicaid expansion couldn't be withdrawn. So there's all of that. And then there's sort of a 7-year history here of the operation of the ACA. The law functions, as we can see, without a penalty. And indeed, there are substantial reliance on the regulations that are in the law. So there's a presumption among a lot of folks that what's likely to happen is that the courts will in some sense, slice and dice the law.
Mike, if I had to ask you to assign probabilities to your four outcomes, I know that's kind of unfair.
Yeah, give me a slide or two.
Okay.
I won't give you a number, but I'll give you a sense. So, I mean, the other thing that can happen with severability is the court could do exactly what the Fifth Circuit did and say, well, we think the law is unconstitutional, but this severability thing is really complicated, and they throw it back to the federal district court to look at it again, which is what the Fifth Circuit did. My sense is if they were going to do that, they'd have just let the case play out and not taken it now. So that seems unlikely. So before sort of going to the end game of severability, there's this really interesting proposal from Cato in an amicus brief that they filed. They're a conservative think tank. And so here's their argument. So their argument is, first of all, there has been harm to the plans. They are limited in their selection of benefits, and the premiums inherent, the premiums that they face are higher because of the presence of those exclusion of pre-existing conditions. But the law is unconstitutional because it lacks that link between the mandate and the penalty. But the redress is to allow people to buy coverage unlimited by essential benefits and the pre-existing condition clauses outside of the exchanges. The rest of the law remains intact. So if you buy that, what that says is the exchanges with its essential benefits, its subsidies, its pre-existing conditions, all would continue. Off the exchange, the market would look like the individual market prior to the ACA. The exchanges would look even more like high-risk pools because it would be just presumably the high-risk people and those with subsidies that are there. And I think we could expect to see, federal subsidies there. And finally, the short-term market would largely disappear because one could buy the kinds of coverage one might want off the exchange.
Mike, for federal subsidies, is this an executive order issue, or is this something that needs to be passed through the Congress?
The presence of the subsidies,
the size of the subsidies.
That's a good question. I suspect it would take some act of Congress. Maybe there's a bit of flexibility there, but I don't think there's a lot. That's a good question.
So we could have a situation where if it's a Republican Senate, they refuse to increase the subsidies.
Sure. So what do we expect? I expect the law is largely left intact. I do think there's probably going to be a severability conclusion. The other answer would be to adopt Justice Roberts' sort of model. But the four conservative justices were not happy with that back in 2012, and maybe things have evolved from that. I suspect they're not happy with that kind of solution. So I think there's a severability story, not necessarily the Cato one. I just thought the Cato one was fascinating. Which brings us, as you've mentioned, to the Biden administration. So the Biden administration, with respect to the ACA, has two major kinds of things. First, they want to put in place a public option within the ACA. This was actually proposed as the House bill back when the law was passed, and for lots of reasons we won't talk about, we didn't go there. So what Vice President Biden has proposed is that there would be a Medicare-like program in which one could purchase health insurance in the exchanges. Now, the thing to appreciate is that's either a big deal or it's not a big deal. It really depends on sort of how big the premiums are for this plan and what kind of subsidies are available through the plan. To the extent that we're talking low subsidies low premiums and high subsidies, then you would expect to see crowd out of private coverage in the exchanges and maybe even in the group markets as well.
So
on the other hand,
I can see this being a problem for insurance companies if it goes to the group market, but insofar
as
to
the individual market too, while admittedly there aren't a whole lot playing there, to the extent that the Medicare-like program is very generous with low premiums, we saw a whole lot of price sensitivity early on, so we should expect to see people shifting in that direction. Out of the group market is, it depends on the extent to which people are willing to give up their employer-sponsored group coverage to get cheap coverage in the individual exchange.
Yeah, because I was wondering if it's just a matter of crowd out of insurance, private insurance in the exchanges, given that the exchanges have sort of generated more sick people and more claims, whether some insurance companies may not just heave a sigh of relief and quit the exchange.
Well, at this point, they seem to have premiums that sort of cover their costs, but given price sensitivity, they may indeed see that market erode pretty dramatically. And of course, a key issue here for providers is this Medicare-like program, to work, is going to have to negotiate with providers over healthcare prices. Maybe they simply assert Medicare prices. Maybe there's a negotiation process, but there's things to be done here to make this work.
Is there any word of negotiation with pharmaceutical companies for drug prices?
Well, the Trump administration has proposed that, and you would anticipate that the Biden administration would as well. But while pharmaceuticals are certainly important, physicians and hospitals are certainly as well. The other thing that the Biden administration has proposed that hasn't gotten nearly as much public attention is when he talks about building on the ACA. What he means is broaden the coverage and expand the subsidies. So, for example, set the maximum payment for insurance to 8.5% of income instead of 9.5%, and presumably scaling that down across the ranges across your income. And then base the subsidy on the second cheapest gold plan rather than on the second cheapest silver plan. That would make the subsidies broader. And indeed remove the upper limit, that 400% that you've talked about, remove the upper limit on access to premium subsidies. So if I have to spend more than 8.5% of my income on health insurance, I can get a subsidy. And then finally, enroll people with premiums below 138% of the federal poverty line in the exchange public option in the states that didn't expand Medicaid. So in Alabama, in Texas, in the Southeast there, the public option would be available for those who had incomes below 138%. Which brings us to sort of a last slide. My sense is it's unlikely that there are going to be major changes that will result from the Biden administration proposals. I mean, I guess we'll know as Alaska and North Carolina and the two Senate seats in Georgia play out. But even with a Democratic majority in the Senate, the sense is that it's not as though one has sort of a huge mandate to be able to do all kinds of things, and it's likely the Republicans will hold the Senate. What you should expect to see is use of executive orders, probably a cutback on those short-term policies, and use of regulations to undo Trump administration policies and to implement new Biden policies to the extent that you can do it through regulation and not go through Congress.
But given this, Mike, there is also the flip side that with the pandemic, with uninsurance, in the states that did not expand Medicaid, there is a growing number of people who are now uninsured, possibly have pre-existing conditions. So isn't there also likely to be at least some political pressure on the swing state Republican senators?
Sure. I'm skeptical that we would see that action across the board. In some states, sure. In others, probably not. But I am skeptical. So what do I see sort of through all of this? So expanded enrollment due to the pandemic, largely in Medicaid, but also in the exchanges. Growth of the short-term enrollment subject to Biden executive orders. The Supreme Court decision that argues that the mandate's unconstitutional, but with severability, and so that the law continues largely unchanged. And the Biden administration efforts to add public choice options and expand the ACA subsidies are limited by by deadlock in Congress. So in some sense, the future of the ACA ex post looks kind of like the future of the ACA ex ante.
Thank you so much, Mike. Okay, I am opening up the chat for questions. So one of the questions we have from Dean Irwin is, so let's say Biden's proposals all take hold, that he can put in a public option, presumably expand subsidies. Are there any estimates floating out there on how that would impact the number of uninsured?
Vice President Biden's team suggests that the uninsured could drop to 1 million, if I remember correctly. But now, though that's a political statement, not an analytic, statement. One would anticipate that there would be substantial reductions. I've not seen hard numbers that I'm willing to attest to. And part of it is going to play out in some crowd out as well. So you'll see a fair amount of shifting as well if all of that happens.
So going back to the original estimates, had every single state expanded Medicaid, the estimate would be we would still have about 20 million uninsured, down from the 47 or whatever, 47 million.
Yes. No, part of that are people who aren't eligible because they're not citizens or long-term residents.
And that would stay. I don't think anybody's proposing.
Well, unless indeed the Congress and the administration was willing to go that step.
Mm-hmm. What about expanding the age up to which young adults can stay on their parents' policies?
I've not heard any sort of discussion of expanding that. Currently, it's through age 25. There is some nice research that suggests that the implication of that is that health insurance premiums for family coverage have gone up, as you would expect. But that seems to have been quite successful in terms of providing coverage to young adults.
And so to go back to the even though you think it's low probability, the sort of extreme option, the Supreme Court says it's all gone, unconstitutional, the entire law is gone, everybody currently covered by it are no longer covered by it. Do you still see the Congress holding its ground on no new health insurance laws, or is it just too murky at that point?
Well, I mean, first of all, we don't expect us to see that kind of decision probably till June. The big decisions usually get announced way at the end of the term. So we would know a fair bit about sort of how well the players are interacting with each other by that time. There's some chance of that. I would be reluctant to sort of bet that we would see a big expansion there.
Gotcha.
I mean, the Trump administration, or at least conservative elements, have proposed some changes, but they're not talking about those kinds of major changes. There are some things that it would be nice to see that the Congress deal with, that both sides have worried about and thought about, having to do with surprise billing and transparency in pricing. And at minimum, those would seem to be good places to start. And if we start seeing those things happening, maybe we'll see others.
So one of the things that we had when the initial Medicaid expansion was proposed was, if states expanded Medicaid for an initial 3 years, there would be 100% federal match to cover those costs. And of course, that's now gone away. Senator Doug Jones had proposed reintroducing it. It went nowhere. We have a question saying, is that something the Biden administration could permit again?
Well, when I, before looking at what the Biden administration had actually proposed, I mean, as I thought about it, I thought that would have been, a nice incremental step that one might take to sort of to back up, it turns out that in the first 3 years of the ACA, if a state chose to participate, the federal government would pick up 100% of its additional claims costs, and now they take 90%. So yes, I mean, that would be a nice incremental step. But if you're going to take the route of a public option approach and expand the subsidies, and it just seems to me that approach to Medicaid expansion probably doesn't happen.
So it would be an either or. Either they go the public option route.
I suspect so.
Okay, gotcha. Thank you, everybody. I'm so glad all of you could join. And Mike, thank you so much. This has been fantastic. Thank you, Lister Hill Center, for helping us do this. And thank you.
Thank you. I learned an awful lot doing this, and this was a lot of fun.